Thank you for a very nice introduction. I would like to talk to you about something that is maybe more a hype than actually something that we should be doing. But as in many things, hypes are very popular. And if you can stick to a certain hype, then you're probably doing a good job. That's what some physicians tend to do. It's like always wanting the newest iPhone or the newest Ferrari. In my case, it's the iPhone, not the Ferrari. Nevertheless, these are my disclosures. What about the biological rationale? Into every new hype, there is actually a good rationale. And there is a good rationale to go for local treatment in metastatic prostate cancer. First of all, there is an improved local control. For example, there are very nice series that show that patients, if you do not operate them or you do not properly irradiate them and you just stick to systemic treatment like ADT, a lot of patients will still be in need for a local treatment. So ADT only does not rule out a local treatment. If you still believe that the primary tumor is the only source of metastasis, well then eradicating this source can actually eradicate further metastasis. And it actually can also improve, a local therapy can improve actually what we get with our systemic treatments only. That's what we know from localized disease and node-positive cancers. And there's also another pro, that's the clonal heterogeneity. I made it simple for me as I'm a radiation oncologist. So this is a tumor, a basic pirate, Likert, whatever you want to call it, with two different types of clones in it. If you just treat this patient with systemic treatment, what you will end up is you will actually reduce the tumor volume, but you might introduce new clones that are resistant. And if you keep on adding newer systemic treatments and so on, and keep on doing that until your patient dies, we know from very nice Nature papers that the clonal heterogeneity will actually explode. And putting it simple, actually, systemic treatment can actually introduce clonal heterogeneity, and it will never cure our patient. On the other hand, what about local treatments? If you do metastasectomy or radiation therapy, I don't really care if I have few clones, more clones, whatever. The end result, I know it's a bit simple, but the end result is the same. So that is a good rationale why probably we should be combining local treatment with systemic treatment, because a local treatment can actually eradicate clones that are resistant, because it doesn't really matter that much. However, there are also some points that we should take into account. These are most often not from clinical trials, but preclinical evidence that actually surgery and also radiotherapy can have not only local effects, but also distant effects. And some of those effects are things that we're not hoping for. For example, we know that surgical wounds can attract certain cytokines that actually can promote invasiveness and can promote metastasis. And the same happens with radiation therapy. Some radiation forms, especially if you don't do them correctly, can actually give rise to new metastasis. You can actually have distant effects. You can have bystander effects. And I have a colleague in Australia that actually says that radiation therapy makes the cancer angry. But I can tell you that if you do it correctly, it doesn't do that. What about the clinical evidence? There's one very nice paper published just a few weeks ago in GCO. And this is actually nicely sums it up. On the blue lines, you can see your good local treatment in combination with systemic treatment. That's radical prostatectomy or decent radiation therapy. If you combine those for a patient with upfront metastatic disease, so that this patient has metastasis, and you compare that with poor radiotherapy, so the dose is too low, or ADT only, the survival difference is enormous. To bear, these are retrospective data, these are registry data, but still the effect is enormous. And I just would like to point out that adding docetaxel for primary metastatic prostate cancer patients gains you a survival benefit of 10 to 14 months. But according to these retrospective data, we might gain even more if we add to these new systemic treatments, we add our local treatment. So this is something we have to look forward to. What about patient selection? There's also a very nice paper recently published showing that if you see these two lines, you've got the orange line on top, and you've got the blue line below. This is actually, here you see the overall survival, and this is the predicted overall survival. And that is actually, you can predict in your patient based on certain risk factors. You can predict how long your patient will live. Don't try to do it by yourself, because physicians are not very good at estimating survival of a patient. But we got nomograms to do that. And if you take a look, there seems to be a very good difference. If we treat these patients with a local treatment, then actually you will gain something. But at a certain spot, when the predicted mortality actually exceeds 70%, then we should stop treating these patients locally. Then there is no benefit anymore. And when you look at the number needed to treat, there appears to be a sweet spot. If your expected mortality is below 50%, your number needed to treat is not that high. If your expected mortality of that certain patient is quite high, then you probably should not add local treatment. So this is the first guidance, that not every patient will actually benefit from this. And that same paper actually gave us a nomogram, how we could do that. For example, this is just a 65-year-old patient with a certain PSA level, no comorbidity, high Gleason, locally advanced, N+, and retroperitoneal disease. And the predicted mortality of such a patient appears to be 51%. Now, if you just make one variable different, that, for example, I now gave that this guy lung metastasis, he ends up with an expected mortality of 75%. So on the left-hand side, you have a patient that a local treatment might be beneficial. On the right-hand side, probably a patient that shouldn't be treated locally, because he will die and he probably needs more aggressive systemic treatment. So these actually can help us now how to select our patient, which patient might benefit the best. This is just a literature overview, and I highlighted actually the flaws of these type of trials, but this is what we have now. And if you just look at them, these are 7 papers. 6 out of 7 are registry data. SEER, the Munich Cancer Registry. These are all very good registries, but they have their flaws. So this is the evidence we have now. There's something, but it's not that much. And there's a potential bias of these case series. And there have been a lot of beautiful things shown in retrospective data, but sometimes we cannot actually prove that this is true. And this is the case with case series. And also remember breast cancer. A lot of people always make the analogy between breast cancer and prostate cancer. This is actually a randomized trial done in breast cancer for metastatic breast cancer patients, giving them local treatment or no local treatment. And there is no difference in survival, although all retrospective data said there should be a big difference, but there wasn't. This shows us that actually we should be very prudent to implement it nowadays. Luckily, there are many, many trials upcoming. And if you want to follow this on your iPad or read whenever you're ready, these are just 2 slides showing that there are a lot of trials coming that want to prove that actually local treatment can benefit some patients. I just highlighted one because everybody knows this one. This is a Stampede. Stampede added a new arm for metastatic disease where radiation therapy will be used to treat the local prostate. And a new trial that still has to open is the SWOG. And the SWOG here will actually do standard of care versus a definitive treatment being surgery or radiation. But they also added something. It is possible to also irradiate the metastasis. And that's the difference, I think, with Stampede. So here they're not only treating the prostate, but also targeting the metastasis. So this is a difference. But there are still many questions to be addressed. Should we only treat the local prostate? Should we treat also the nodes preventively? Should we also target the metastasis, yes or no? Which is the best strategy? Which is the best order? First give systemic treatment, then do the local treatment. Do the local treatment first, then systemic treatment. So there are many, many questions that still haven't been resolved. And also at the end, we need to know which patient benefits, because at this time we already know that not every patient will benefit from this strategy. So for me, it's still a hype. And I think we are still at this beautiful end where the people doing it are the innovators, but I think we are not ready to put it in the mass market. I don't think we're still using these things nowadays. We're trying to evolve now from the innovators to the early adapters in trials and trying to get it that we can do it for everybody, actually, if the proof is there. But for now, I think it's not ready for this prime time yet. So for me to conclude that a local treatment in an upfront metastatic patient, you can consider that, but only in certain specific circumstances. For example, if you have a local patient that has local symptoms, then it's something that you could consider, but then do a good local treatment. Also, if you want to avoid certain symptoms, that will be your ideal patient. Thank you.